Pathophysiology, Pharmacology 571, Constipation Case Study by Jacqueline Jones. Chief complaint, Carrie Reynolds, age 64, is a female. I feel just awful ever since starting these pain pills. I think I'd rather be in pain. HPI presents to the ED complaining of increasing abdominal pain, cramping, and nausea for several days and now vomiting for the past several hours. 2 weeks ago, she was put on Percocet therapy. She's post-procedural pain association with the right total knee orthoplasty. Her last bowel movement was 6 days ago. Not feeling well times 4 days. Her symptoms include bloating, decreased appetite, decreased thirst, and fatigue. Reports today, cramping was at its worst. Reports yesterday, sorry. Completed a couple of doses of Metamucil, which was no help. The past medical history, she has hypothyroidism, diabetes type 2, hypertension, dyslipidemia, osteoarthritis. She's married, social worker, quit smoking over 20 years ago. Family history of mother's healthy in her 80s, father died of heart disease in his 60s. She has 3 brothers, 3 sisters. 1 brother have type 2 diabetes. She has 2 healthy sons. Pathophysiology. OIC is opiate-induced constipation, which is caused by opioid medication via direct agonism of induced opioid receptors, which are abundant throughout the GI tract, the direct effect of which results in delayed GI transit. Decreased secretions of electrolytes, resulting in increased fluid absorption and increased sphincter tone with impaired reflex relaxation following rectal distension. Additional induced opioid receptors are widely distributed throughout the central and peripheral nervous system. Therefore, it is important to strike a balance between pain relieving efforts of the opioid analgesics, which are primarily mediated by agonism at central induced opioid receptors and at the risk of GI effects of opioids such as OICs, which can compromise the potential clinical benefits of opioid analgesics by patients choosing to decrease or stop the use of opioid medications to self-manage their OIC and facilitate a bowel movement. The medications is diltiazem, chlorothiazide, levothyroxine, metformin, simvastatin, multivitamin, warfarin, and Percocet. Chlorothiazide is an antihypertension, thiazide diuretic. Its mechanism is help prevent the body from absorbing too much salt. Fluids can cause retention. Levothyroxine treats her hypothyroidism, replaces the normal serum levels of T4 and T3. The metformin is the non-sulfonylureas, reduces intestinal uptake and hepatic production of glucose. Simvastatin treats the the lipid disorder. It blocks the synthesis of cholesterol in the liver by competitively inhibiting the HMG CoA reductase activity. Multivitamins contains minerals, participate in enzymatic reactions in the body, or function as a hormone signaling molecular and structural elements. Metformin is an anticoagulant antagonized. Vitamin K interferes with the synthesis of vitamin K dependent clotting factors 2, 7, 9, and 10. Percocet is an opioid, and agonist that blocks or reverses opiates by competing at the receptor sites and reversing respiratory depression, hypotension, and sedation. The physical exam, she was a pleasant lady, but you could tell she was in distress due to her abdominal discomfort. It was visual, uncomfortable, and she was holding her stomach. Her vital signs, her pulse was a little Brady 57. Her waist circumference was 37, which was distended. She had a decrease in bowel sounds. Her stool was palpable at the left side and also at the rectal vault. Status post the right TKA, the wound is healing, and her glucose was elevated, was 133, and so was her creatinine. And some identifiers was type 2 diabetes, hypertension, hypothyroidism, hyperlipidemia, osteoarthritis. The signs and symptoms indicative of constipation was abdominal tenderness, cramping, bloating, and distension. Nausea and vomiting, no BM times 6 days, decreased appetite, thirst, and fatigue. Opiate post-op times 2 weeks. Identification, possible non-pharmacological contributions for constipation is inadequate diet, limited amount of vegetables, fruits, grain, water intake, inability to move at her due to her move normal due to her TKA, taking Percocet 2 tablets 4 times a day, possible pharmacologic contributions for constipation is diltiazem. One of the side effects is constipation. Calcium channel blocker, nausea, low blood pressure also. Warfarin, constipation, that's another side effect also. Information to be obtained from the patient for constipation. Last BM, and what did it look like? The frequency, the consistency, the pattern, the medication list, taking OTC laxatives, the diet, the fluid intake, the exercise, the signs of abdominal tenderness and distension. Desired outcome is to send the patient home without a laxative, educate the patient on how to manage and maintain a diet with fiber, fluids, and exercise while taking the opiates. Do not overuse the laxative. Do not try other OCT laxative without consulting with your pharmacy or with her MD. Sometimes patients feel they have to have laxative with two different types of ingredients in it, and it's better that they have one instead of two because of the type of medications they could be on. And make a plan to return back to their daily routine that she was doing before her TKA, and we could prescribe a PRN laxative for a short period for no more than a week while she's on her last week of opiate. That would be the last resort, just if the patient feels uncomfortable going home without something. And some of the opiates, the different types of laxatives. The oral osmotic, it would be like the milk and magnesia, the Miralax, and what it does is it draws water into the colon to allow easier passage of stool, but the side effect is bloating, cramping, diarrhea, nausea, gas, increased thirst. And another type is the oral bulk former, and that's your benefiber, your citracil, your fibercon, your metamucil, absorbs water to form soft, prompting normal contractions in intestinal muscles, bloating, gas, cramping, or increased constipation if not taken with enough water. And then you have your oral stool softener is Colase surfact. Add moisture to the stool to allow strain-free bowel movements. Electrolytes imbalance with prolonged use. The oral stimulant is Dulcolax Synecot. It triggers rhythmic contractions of the intestinal muscles to eliminate stool, and the side effects is belching, cramping, abdominal nausea, urine discoloration with the Seneca. And also you have your rectal suppositories, and that will be your Dulcolax and your Peterlax. And it triggers rhythmic contractions of the intestinal muscles and softens the stool. The one I looked at for this patient would be the stool softener, so that it would just add moisture to the stool to allow strain-free bowel movements. And I really feel like she could go home without any stool softener because she did get disimpacted. And if she would pick up her regimen, of having fiber in her diet and getting her exercise in, that it would help a whole lot. She's not able to move as much as she usually does, but there is some exercises that the doctor would be having her to do. So to get her back to her normal routine, that would be great. And then the therapeutic alternatives would be her diet with at least 30 grams of fiber per day for her age of greater than 50, and her fluid water, because then she could use unsweetened coconut water, and that unsweetened coconut water is very good. It it's supposed to be excellent. It's an excellent way to relieve constipation, because it contains electrolytes that prevent dehydration and cleans out the digestive and urinary tract. Coconut water is essentially high in potassium, which is needed for electrolyte balance in the body. Look for unsweetened brands, as added sugar may further irritate the digestive system. And Colace is a laxative prescribed to treat occasional constipation as well as constipation associated with certain medical conditions. The active ingredients in Colace works by allowing the water and the fat to get into the stool. This helps soften the stool and makes the passing stool more comfortable. Your doctor may recommend stool softeners such as Dulcolax, as well as the first method used for preventing and treating constipation. Your optimal plan: surfactant stool softeners because they reduce the surface tension of the oil and water interface on the stool and facilitates admixture of fat and water into the stool, producing an emollient action. Surfactants are most beneficial when stools are hard and dry. In anorectal conditions, which pass from firm stool, is painful, and in situations where straining at stool is avoided. And Colace, if we would order some Colace for her, it would be the 100 milligram soft gel tablets. She would take one twice a day with a full glass of water. It's really important that they take a full glass of water so it will loosen up and facilitate peristalsis in the intestines. And she wouldn't use it for more than 1 week. And the common side effects is bitter taste, cramping, diarrhea, gas, irritation around the perianal and throat irritation, rectal bleeding. And she also had to be cautious with her bleeding because she is on Coumadin as a as a prophylactic for having her surgery, so she won't develop a DVT, so she's not moving at her normal routine. And her outcome is to get her back to her routine evacuation of her stools, discharge instructions and pain and plan was clear to the patient, educating the patient is making her aware to keep a daily routine evacuation, and patient is able to repeat back the verbal instructions for side effects of opioids, the purpose of the Colace, lifestyle changes to prevent constipation. Patient is able to control and manage her constipation. And with constipation, there's a number of factors like poor diet, physical inactivity. Some medications can cause it, disruptive normal bowel function, and fewer BMs than what you're normally used to. And with her clinical course, patient returned for follow-up and reported that she was having her left knee done. And so the measures we would take to prevent constipation while she's taking her opiates, we want to remind her that she needs to increase that fiber in her diet and have water and exercise as as recommended by her surgeon. And you also want to make sure that she limits her fruit intake because she is a diabetic. So you want to do like 2 to 3 fruits per day. And you can look at nuts and you want to look at other things that she could use. She needs to avoid as much sugar as possible. With patient education, you want to educate her on constipation, the signs and symptoms of constipation. There will be like probably some leaking um, from her rectal, where it's watery, oozing stool, because it's the liquid is trying to get around the hard stool. And she want to pay attention to the her daily. She wants a daily routine of keeping a diary of her how many times she used the bathroom. She wants to establish a regular evacuation, usually after her meals, and avoid decreased intake of foods with white sugar, pasta, pastries, cheese, and white rice. And those will also help her with her diabetes. And she really has to limit herself also to the green leafy vegetables due to her vitamin K. And she can also, we would encourage her to drink a warm glass of water, like a half an hour, a warm glass of whatever, coffee, tea, whatever she would drink in the morning time, a half an hour before her breakfast to help stimulate her bowels. Thank you.